So ARASENS is a study looking at the benefit of darolutamide in patients for who the treatment is androgen deprivation therapy and docetaxel. We are speaking about newly diagnosed metastatic hormone-sensitive prostate cancer. There's been a lot of development in these patients. This is one of the only trials that was specifically designed to address the question of adding one of these AR pathway inhibitors on top of ADT and docetaxel, which was considered a standard of care for many years. So the study design was very simple. These were patient candidates for ADT plus docetaxel with newly diagnosed metastatic hormone-naive prostate cancer. There was very, very little selection criteria. We wanted the investigator to decide whether the patient was fit for ADT plus docetaxel. Then the patient would be randomized, placebo versus darolutamide 600 milligrams twice a day until progression. So the main result is the fact that it increased overall survival. So no, everybody would say, oh, okay, that was expected. But keep in mind, we've been doing more than 30 trials with docetaxel in metastatic CRPC. None of them were positive. So it was still a very important hurdle. There's been trials with ADT, apalutamide, and enzalutamide. They were not that conclusive. There was one with abiraterone, but we believe it was someone very important goal to achieve. And we believe we did so because the drug fit maybe more for purpose, because darolutamide has very low drug-drug interaction profile and very low added toxicity, something we see in that trial as well. I think that the impact of that trial is now we are rethinking about who could benefit from what we call a triplet therapy, meaning when should we give docetaxel? And clearly there are patients with very aggressive disease, high volume, highly indifferentiated trial, for which we as faculty believe they should receive docetaxel up front. In that scenario, if we want to combine with an AR pathway inhibitor, it needs to be a drug that shows efficacy and also that is not compromising quality of life and the side effect profile. So I think that's what we show. It is today feasible and safe to administer a triplet treatment of ADT, docetaxel, and an AR pathway inhibitor in very high-risk mHSPC patients. So what is next now is to make a better job with all these drugs, to optimize the treatment, better identify who's benefiting from triplet, from doublet. Do we have to treat everybody forever? Is there a patient we can de-escalate? So I think that awaiting a next generation of drug, we should really focus on tailoring the treatment to individual patients, because what we have so far is trial looking at a very large group of similar patients.